In order to understand the underlying causes of depression, we first need to be able to answer the question, what is depression? Humans have probably dealt with depression since the advent of civilization, and possibly earlier. Hippocrates referred to this disorder as melancholia. He defined it as a prolonged fear and sadness, and believed it was caused by an excess of black bile in the spleen. Although his explanation for the disorder isn't supported by modern medicine, his definition is largely reminiscent of ours today. The Diagnostic and Statistical Manual of Mental Disorders is the authority on mental disorders in America. It's the reference which doctors use to define and diagnose mental disorders. In the manual, depression is not classified as a single disorder, but rather a cluster of disorders known as the depressive disorders. These disorders are classified as mood disorders and include major depressive disorder, disruptive mood dysregulation disorder, persistent depressive disorder, and more. Major depressive disorder, or MDD, is the most commonly diagnosed among the group and is the disorder that most people refer to when they use the word depression. MDD is defined as a 2-week episode where an individual experiences 5 or more depressive symptoms. The manual includes 9 depressive symptoms. These symptoms can range anywhere from having a depressed mood most of the day, nearly every day, to significant changes in your weight, to recurrent thoughts of death, suicidal ideation, or a suicide attempt. Based on the severity of these symptoms and the amount that they affect a person's life, one can be diagnosed with mild, moderate, or severe major depressive disorder. While this list is extremely useful for identifying and diagnosing depression, it's not necessarily perfect. This definition represents depression to the best of our current knowledge. As our understanding of depressive disorders improves, our definition for them continues to change. For example, the DSM-4 contained a bereavement exclusion that eliminated a depression diagnosis in patients that recently lost a loved one. This was omitted in the 5th edition under the explanation that a death can induce depression that goes beyond a normal grief response. This is to say, while it's easy to give a vague definition for depression, we continue to struggle to strictly define the limits of the disorder. Compared to other public health problems such as obesity, cancer, drunk driving, and substance abuse, depression doesn't seem to be as concerning in the public sphere. This justifiably could be due to the high prevalence and extreme outcomes of some of these issues, but part of it could be derived from the stigma that mental health issues continue to carry. Nevertheless, depression has a significant impact on our country that many may not realize. Major depressive disorder affects 15 million Americans a year. 7% of the population 18 and older will be affected by the condition. Possibly more shocking than that, depression is the leading cause of disability in the U.S. for those ages 15 to 45. In terms of treatment and lost productivity, depression costs Americans $210 billion a year. Whether you're a humanist or an economist, depression is a significant issue in America. Certainly the pharmaceutical industry has noticed this problem and has done their best to capitalize on it. Between the period of 1988 and 2005, Americans stepped up their antidepressant consumption 400%. Now, I'm all for treating depressed patients, but are the people getting what they're paying for? A look into the American suicide rate raises even greater reason for concern. While modern medicine has been able to produce cures and preventative measures that have reduced rates of many diseases that have plagued the human race, those results have not been replicated among the suicide statistics. A report released in 2014 by the CDC revealed that suicide rates are rising steadily. From 1999 to 2014, the suicide rate for the entire population increased by 24%. In 2014, suicide claimed 42,826 American lives and was the number 2 cause of death among those aged 10 to 34 years old. The report also found that teenage and female suicide rates were rising faster than the American average. Some have proposed that cultural and socio-economic changes amongst the population are responsible for those rise in rates. While it's difficult to pinpoint an exact cause for this rise in suicide rates, It is telling of a growing problem and the need for a novel solution. So now that I've laid down the foundation about what depression is, we can try to tackle the question about what causes depression. In order to understand how we think about depression, we need to go back to the discovery of the first antidepressant, monoamine oxidase inhibitors. These were discovered in the 1950s when doctors, hoping to find a cure for tuberculosis, gave it to their patients. Unfortunately, the patients did not receive a cure for their tuberculosis, but the doctors did note that the patients were happier after receiving monoamine oxidase inhibitors. Based on this discovery, the monoamine hypothesis for depression was formed. Monoamines are a class of neurotransmitters which include serotonin, dopamine, and norepinephrine. Neurotransmitters are the molecules that allow neurons to communicate with one another. Upon receiving a signal in the form of an action potential, the presynaptic neuron releases neurotransmitters into the synaptic space. These neurotransmitters then bind to receptors on the postsynaptic neuron. These receptors open up channels which allow ions to flow across the cellular membrane, thus inducing an action potential in the postsynaptic neuron. Neurotransmitters are then reabsorbed by the presynaptic neuron, where they can be recycled and reused, or they are broken down in the cell by monoamine oxidases. If these monoamine oxidases are inhibited, the levels of monoamine neurotransmitters rises. Potentially, this extra availability of neurotransmitters would make it easier for cells to communicate with one another. Thus, this gave rise to the theory that depression was caused by low levels of monoamine neurotransmitters in the brain. While these drugs provided one of the first effective treatments for depression, they were far from perfect. They inhibit monoamine oxidase activity throughout the entire body. 80% of serotonin is found in the gastrointestinal system and not in the brain. Because of this, they came with many side effects and left researchers searching for new treatment options. The next generation of treatment for depression came in the form of selective serotonin reuptake inhibitors. These drugs work by inhibiting the activity of specific serotonin reuptake channels. This specificity allows them to block the reuptake of serotonin into specific neurons and not others, limiting their side effects. By blocking the reuptake of serotonin, the neurotransmitter sits in the synapse for longer. Potentially, this means more neurotransmitters will dock to receptors and messages will be transmitted more readily. These drugs gave rise to the idea that serotonin is the feel-good molecule. Prozac was the first of this generation of antidepressants to be discovered, but there are many like it, and they all work based on the same mechanism. This group of antidepressants makes up virtually all of the prescribed antidepressants of today. Since Prozac's discovery in 1988, antidepressant usage by Americans has increased by 400%. This statistic was actually released 10 years ago in 2005, but I would bet that our consumption has only grown since then. Although SSRIs are widely prescribed and used by the American public, they are still far from perfect. First off, these drugs are far from 100% effective. Most specific SSRIs have below a 50% response rate. Because of this, doctors often have to use a guess and check technique in order to find a drug that will produce results. Often, doctors are forced to prescribe multiple types of antidepressants in hopes their patients will respond to a cocktail of antidepressants. Even with these techniques, doctors find that modern antidepressants aren't capable of treating depression in all of their patients. Patients who struggle to respond to modern depressant treatments are said to have treatment-resistant depression. A massive study with 4,000 patients over a course of 6 years was conducted to test the efficacy of modern antidepressants. The study had 4 consecutive levels of treatment, with patients advancing to the next if they don't respond to the first. The study included SSRIs, another type of antidepressant similar to SSRIs, but that works on a different type of receptor, a type of tricyclic antidepressant, and then finally, as a last case treatment option, they used a monoamine oxidase inhibitor. The study found that 70% of those who did not withdraw from the study became symptom-free. Although this rate of remission is quite impressive, if you look a little deeper into the details, it doesn't seem quite as perfect. First off, 30% of patients still struggled with depression after 5 years of treatment with 4 or more different types of antidepressants. That's extensive treatment to only receive 2 out of 3 positive results. Secondly, the results only count patients who did not withdraw from the study. 21% of patients withdrew after level 1, 30% withdrew after level 2, and 42% withdrew after level 3. This could be telling of the side effects that these drugs carry, or just related to other complications that those with depression have to deal with. Overall, the total rate was probably lower than that reported. This study is evidence that modern antidepressants are inadequate at treating the disorder. Despite this inadequacy, the side effects these drugs carry are often even more troubling. Even though SSRIs are much safer than the first generation of antidepressants, they still carry a laundry list of side effects on their labels. Perhaps the most drastic of these is their tendency to increase suicidal thoughts in children, teens, and young adults. Finally, even when these drugs do work as intended, they take between 2 and 6 weeks to work. For individuals with severe depression, this could be too long. This waiting period is also evidence of our incomplete understanding of depression. The monoamine theory bases itself on low levels of serotonin in the brain. These drugs raise serotonin levels nearly immediately, but their effects take much longer to be felt. This unanswered question has pushed researchers to continue looking for the underlying basis of depression. So now that I've introduced our current understanding of depression and treatment methods, we're going to shift pace and talk about ketamine. Ketamine is classified by the United States government as a Class 3 drug. This means that the drug currently has an accepted medical use in the United States and that it has less potential for abuse than drugs in Schedules 1 and 2. The drug is a dissociative, which basically means it disconnects the central nervous system from outside stimuli, leaving the patient in a state of sensory isolation. For this reason, the drug was first introduced as an anesthetic. In 1970, it came onto the market, introduced as a rapidly acting, non-barbiturate general anesthetic. One of the most attractive features of this drug is its power sedative ability while stabilizing respiratory and cardiovascular systems. This means the drug is extremely useful in emergency procedures where the patient's medical history may not be known. The drug has received some stigma in the medical community due to its heavy psychological effects and is more commonly used in veterinary practice. Some stigma is also received from the recreational use of the drug, where users induce confusion, hallucinations, and in extremely high doses, what the users call a K-hole, where they experience completely dissociation from reality. The drug also has a potential for dependence and abuse, which is another reason why doctors shy away from the drug. As one doctor said, ketamine is a dirty, dirty drug. It goes a lot of places and it does a lot of things. While some of its effects are useful for medical purposes, it's not clear what else the drug does. In the 90s, researchers began to test a new hypothesis for the basis of depression, which implicated the NMDA receptor. Inescapable stress inhibits the induction of long-term potentiation in the hippocampus. This process is mediated by the NMDA receptor. Since inescapable stress also produces a syndrome of behavioral depression, researchers hypothesized that the NMDA receptor could be a target for antidepressant treatment. Initial research did show that NMDA receptor antagonists had antidepressant qualities in animal models. The NMDA receptor is a glutamatergic receptor that is both ligand and ion-gated. It requires the binding of both glutamate and glycine in order to induce a conformational change and open the gate, although this isn't sufficient to allow ions through. Even with both these neurotransmitters bound to the receptor, the channel is still blocked by a magnesium ion. This magnesium ion is displaced when the membrane is depolarized. Only when both these conditions are met are calcium ions allowed through the channel. The NMDA receptor is responsible for many processes and is crucial during neural development stages. Activation of the NMDA receptor can induce long-term potentiation and therefore is crucial in synaptic plasticity. This receptor doesn't work alone in these processes, but works alongside another glutamatergic receptor known as the AMPA receptor. The AMPA receptor is responsible for the depolarization of the membrane, which allows the magnesium ion to become dislodged from the NMDA receptor. Activation of the NMDA receptor is associated with an increase in brain-derived neurotrophic factors, resulting in the transcription of AMPA receptor RNA and eventually the translation and increase of AMPA receptors on the synapse. An increase in AMPA receptors on the postsynaptic neuron allow messages to be received more readily. Ketamine was a known NMDA antagonist. For this reason, researchers tested it for its antidepressant qualities. This study from 2006 compares the antidepressant qualities of ketamine to a placebo. Patients were injected with a half milligram of ketamine per kilogram of the patient's weight. Researchers then evaluated the severity of patients' depression at 40, 80, 110, and 230 minutes, a day after, 2 days after, 3 days after, and 7 days after. They evaluated the patient's depression with the Hamilton Depression Rating Scale. This is a 21-item questionnaire intended to assess the level of depression in patients. It is the most widely used depression assessment scale. A score between 0 and 7 is generally accepted to be within normal range, while a score of 20 is generally associated with moderate depression. The figure on the left shows average HDRS score for the patients in the trial. Patients in both groups began at a score of around 25. 1 day after being treated with ketamine, the average score dropped to 12, while the placebo group hovered around 23. The difference between the groups reached a statistical significance at 110 minutes and stayed significant for 7 days, which was the last assessment time point. The figure on the right shows the response rate between the two groups. Researchers defined a response as a 50% or greater drop in the HDRS score. 24 hours after ketamine administration, 70% of patients had responded to the treatment. Early researchers also noted that ketamine had an ability to decrease suicidal thoughts and intentions in patients. This 2014 study sought out to quantify this effect. In this study, 49 patients received 0.2 milligrams of ketamine per kilogram of body weight. They were subsequently evaluated for suicidal ideation using a scale for suicidal ideation. This is a 19-item survey with each question being rated 0, 1, or 2 for a maximum score of 38. Before treatment with ketamine, the average SSI of patients in the study was 23. They were then evaluated at 40, 80, and 120 minute time points. After 120 minutes, the average score dropped to only 13. Both these studies show the great potential for ketamine in antidepressant treatment. The first study revealed two exciting qualities of ketamine. First, patients felt antidepressant effects within 2 hours. This is incredibly quick compared to the 2 to 6 week response time of most modern-day antidepressants. Secondly, the researchers found that the effects lasted for a week. Patients still felt the antidepressant effects long after the ketamine had left their bloodstream. This is significant because it shows that the relief felt by the patients isn't temporarily induced by the presence of ketamine in their system, but rather that the ketamine is causing lasting changes in the brains of the patients. This second study is equally exciting in the context of antidepressant treatment. While another pitfall of SSRIs is their tendency to induce suicidal thoughts and behaviors in their patients, ketamine is shown to do the opposite, and it does so very rapidly. This shows ketamine's massive potential in severely depressed and suicidal patients, when doctors' often only goal is to get them to their next checkup. Despite the positive results in these studies, ketamine has still not been approved for use in antidepressant treatment. This is due to an overall lack of research into ketamine's antidepressant qualities and the unknown effects of long-term ketamine usage. While there have been 12 studies investigating the antidepressant effects of ketamine in depressed and bipolar patients, the results from the study are mostly preliminary with limited numbers of patients involved in the studies. Ketamine's dissociative side effects and high potential for abuse reduce its viability as a treatment for depression. A recent study by a group of researchers from Maryland University has proposed a novel mechanism for ketamine's antidepressant effects. Their research identifies one of ketamine's metabolite as the responsible factor for ketamine's antidepressant qualities. It was previously thought that ketamine's antidepressant qualities came from its NMDA receptor antagonistic effects. This research proposes a new mechanism which doesn't implicate NMDAR inhibition. Researchers used a number of animal models in order to quantify the level of antidepressant effects of these drugs. One of these is known as the forced swim test. Researchers place a mouse in a walled container of water where they cannot escape for 6 minutes. The test is videotaped, and then the researchers can go back and score the test afterwards. Researchers look at the last 4 minutes of video and determine how long the mouse was either swimming and trying to escape or just floating sedentarily. When the mouse is just floating and not trying to escape, this is counted as immobility time. High immobility times are associated with depression, while more motivated mice will attempt to escape for longer. The research group first sought to test the hypothesis that NMDA inhibition is the mechanism responsible for ketamine's antidepressant qualities. They did this by comparing the antidepressant effects of two enantiomers of ketamine. What is referred to as ketamine is actually comprised of 50% S-ketamine and 50% R-ketamine. The S-ketamine binds to NMDA receptors at a 3 to 4 times greater rate than R-ketamine. If NMDA inhibition is the responsible mechanism for ketamine's antidepressant qualities, S-ketamine should produce greater antidepressant effects. This figure shows the level of antidepressant effects at 1 hour and 24 hours after administration of 1, 3, 10, and 30 milligrams per kilogram of ketamine, compared to a saline control. S-ketamine only produced significant results in the 1 hour time point at 30 milligrams per kilogram. This is contrasted with R-ketamine's antidepressant effects, which were significant at the 3, 10, and 30 milligrams per kilogram at 1 hour. This is the opposite effect one would expect if NMDAR inhibition was the mechanism by which ketamine worked. Additionally, we see significant antidepressant effects of the 10 and 30 milligrams per kilogram of R-ketamine 24 hours after administration. This is consistent with the sustained antidepressant effects seen in other ketamine studies. The researchers replicated these results in 2 other animal model tests, known as the novelty suppressed feeding test and the learned helplessness test. Both produced similar results. Subsequently, the researchers investigated brain levels of S versus R-ketamine after ketamine administration. Potentially, if R-ketamine was more readily localized into the brain or S-ketamine was metabolized quicker, this could be responsible for the more drastic effects of R-ketamine. The researchers analyzed the level of ketamine in mice brains after 10, 30, 60, and 120 minutes and found identical levels between S and R-ketamine. This led the researchers to believe that the enantiomers had different effects due to different biochemical qualities, and not just different levels in the brain. Previous research has shown that ketamine produces different levels of antidepressant effects in female versus male mice. The researchers thought that investigating this difference could lead them towards the mechanism for ketamine's antidepressant effects. First, the researchers wished to reproduce these results. Here we can see the levels of antidepressant effects measured in the forced swim test by immobility time in male versus female mice 24 hours after administration with 1, 3, and 10 milligrams of ketamine, a mixture of both the R and S enantiomers. We see significant effects in only the 10 milligram group for males, but both the 3 and 10 milligrams per kilogram group for females. This suggests that ketamine is a 3 times more potent antidepressant in female mice than male mice. The researchers thought that perhaps male and female mice metabolized ketamine differently, and this was responsible for the different levels of antidepressant effects. In order to investigate this hypothesis, the researchers first analyzed what metabolites are found in high concentration after administration of ketamine. On the left, we can see the levels of ketamine and its various metabolites in the circulating bloodstream of mice 10, 30, 60, 120, and 240 minutes after administration. Ketamine, along with its metabolites norketamine and 2S6S, 2R6R, HNK, are the only substances found in substantial amounts after ketamine administration. On the right, you can see a simplified diagram of how these 3 substances are brought about. Ketamine is metabolized into norketamine, and 2S6S, 2R6R, HK. Both of these metabolites are in turn further metabolized into 2S6S, 2R6R, HNK. The researchers investigated the levels of ketamine, norketamine, and 2S6S, 2R6R-HNK in female and male mice due to those results found in the last experiment. The researchers found that ketamine brain levels were identical between the genders, and norketamine levels were similar between the genders, although males had slightly higher brain levels at the 30-minute time point. The real difference was found in the 2S6S and 2R6R-HNK brain levels, where female mice were found to have 3 times greater levels at the 10, 30, and 60-minute time points. This is reminiscent of ketamine's 3-fold potency increase in female mice compared to male mice. This led the researchers to believe that this metabolite was primarily responsible for ketamine's antidepressant effects. In order to investigate whether 2S6S, 2R6R-HNK is responsible for ketamine's antidepressant effects, the researchers needed to find a way to compare the antidepressant effects of ketamine with and without the presence of the 2S6S, 2R6R-HNK metabolite. This is difficult because they're not administering this molecule, but rather it's being metabolized from ketamine. In order to do this, the researchers needed to find a way to block the metabolism of ketamine into 2S6S, 2R6R-HNK. They accomplished this by deuterating ketamine at the C6 position. What this means is they substituted the normal hydrogen atom at this position for a deuterium atom. Deuterium is an isotope of hydrogen, also known as heavy hydrogen, that contains a neutron in its nucleus, where normal hydrogen does not. While this alteration should not change the pharmacological properties of ketamine, it could change the rate or the way that ketamine is metabolized. Indeed, the researchers found that the deuterated ketamine was metabolized into 2S6S, 2R6R-HNK at a greatly depressed rate. The researchers compared the antidepressant effects of ketamine and deuterated ketamine by using the forced swim test 1 in 24 hours after administration of the drugs. While both ketamine and deuterated ketamine produced substantial and similar results at the 1-hour time point, the results differed after 24 hours. The antidepressant effects of deuterated ketamine at this time point were no different than the control, while ketamine's effects were significantly different than both the control and the deuterated ketamine. This supports the hypothesis that 2S6S, 2R6R-HNK is responsible for the sustained antidepressant effects of ketamine. Next, the researchers investigated whether 2R6R-HNK was differently potent than 2S6S-HNK, due to the differences they had noticed earlier between the level of effect of S-ketamine and R-ketamine. The researchers used the forced swim test 24 hours after administering mice with ketamine, 2S6S-HNK, and 2R6R-HNK. In this test, they found that at 10 mg per kilogram, 2R6R-HNK produced significant sustained antidepressant effects. At these same levels, 2S6S-HNK did not produce significant effects. This reinforces the first experiment that showed R-ketamine was a more potent antidepressant than S-ketamine, and identifies 2R6R-HNK as the primary metabolite responsible for ketamine's sustained antidepressant effects. Next, the researchers sought to propose a mechanism by which 2R6R-HNK works. First, they investigated the HNK metabolite's NMDA receptor antagonism effects. This would test whether the previously proposed NMDAR inhibition hypothesis was the mechanism by which these metabolites acted. I'm honestly not 100% sure how this next experiment worked, but I'll explain it to the best of my understanding. The researchers first dissected mouse brains and obtained hippocampal slices. They used standard patch clamp techniques in order to obtain recordings from single neurons in the CA1 stratum radium. The part that I don't fully understand is how they isolated NMDA evoked currents, but they treated the cells with a muscarinic antagonist and a GABA antagonist, and applied 50 micromoles of NMDA directly to the neurons using a specially adapted U-tube. The field potentials were invoked by a stimulus of 150% of the threshold intensity. On the left, we can see that the control and both the HNK metabolites do not inhibit NMDA receptor activity due to the consistent readout of both the HNK groups, similar to the control. This is contrasted with the ketamine group, where we see a lower response once ketamine is applied to the neuron, This is indicative of NMDA inhibition. We can see these results quantified to the right as compared to the control group. Both of the H and K groups have a response of 100% of the control, while ketamine results in a 50% inhibition of response. Finally, researchers tested the role of the AMPA receptor in ketamine and its metabolite 2R6R-HNK's antidepressant effects. This receptor works alongside the NMDA receptor when initiating long-term potentiation. The researchers used MBQX, which is an AMPA antagonist, to see whether activation of the AMPA receptor is responsible for ketamine and its metabolites' sustained antidepressant effects. NBQX would inhibit the activation of the AMPA receptor and negate the antidepressant effects brought about by the activation of this receptor. They found that the significant sustained antidepressant effects brought about by ketamine were negated in the presence of NBQX. The same result was found with 2R6R-HNK, with NBQX negating its effects. These experiments seem to show that ketamine's AMPA agonistic qualities are responsible for its antidepressant effects, rather than its NMDA antagonistic effects. AMPA receptor activation is the mechanism by which ketamine's antidepressant qualities are brought about, rather than NMDA inhibition. The final experiment that the researchers did, and possibly the most exciting in terms of future treatments for depression, showed that the HNK metabolites do not produce the same negative effects of ketamine. One of the main reasons why ketamine has not been used as a widespread antidepressant are due to its addictive and dissociative effects. The experiment shown in the figure on the left allowed mice to self-administer ketamine or 2R6R-HNK. Mice were first trained to press the lever in order to receive water. After this, they were surgically implanted with a catheter that was constantly connected to them. After pressing the lever, they would receive a solution through this catheter. This solution was either saline, which was the control, or differing amounts of the drug ketamine and its metabolite 2R6R-HNK. While presence of ketamine in the solution they received in their catheter greatly increased the number of lever presses by the mice, the metabolite 2R6R-HNK did not receive the same increase in lever presses. This shows that the metabolite does not have the same addictive qualities as ketamine. The figure on the right shows an experiment used to test the dissociative effects of the drugs. In this test, mice are placed on a rotating cylinder and are timed to see how long it takes them to fall off. Over the course of the 3-minute experiment, the rod accelerates from 5 rounds per minute to 20 rounds per minute, making it more and more difficult for the mouse to stay on. The control group, which was injected with saline, lasted around 175 seconds. This average was replicated by the HNK groups, which were injected with 25 milligrams per kilogram and 125 milligrams per kilogram of 2R6R-HNK. These results are greatly contrasted with the ketamine group, which was injected with only 10 milligrams per kilogram, but whose average time was only 25 seconds 5 minutes post-injection and 75 seconds 10 minutes post-injection. This shows that ketamine produces discoordination due to its dissociative effects, while 2R6R-HNK does not. Potentially, this means that the metabolite 2R6R-HNK could be successfully used for quick and powerful antidepressant treatment without carrying ketamine's dangerous side effects. In conclusion, ketamine presents exciting possibilities for the future of treatment of depression. Its antidepressant qualities overcome the pitfalls of modern-day antidepressants, namely their tendency to induce suicidal ideation, the 2 to 6 week waiting period between administration of treatment and the realization of antidepressant effects, and their low response rates. Ketamine itself has pushed forward our understanding of depression and has helped support the hypothesis that depression is largely regulated by the glutamatergic system and related to synaptic plasticity induced by long-term potentiation by the NMDA receptor and AMPA receptor. Recent research into ketamine's mechanism has revealed that the former hypothesis that ketamine's NMDA antagonistic effects are not responsible for its long-term antidepressant effects. In fact, a single metabolite, the 2R6R-HNK, is responsible for the antidepressant effects which are induced by activation of the AMPA receptor. Not only is this finding exciting for furthering our understanding of depression and possibly a more nuanced view of the glutamatergic hypothesis for depression, but also because the metabolite opens up new treatment possibilities for future antidepressants. This metabolite carries with it all the positive, rapid-acting, and powerful antidepressant effects of ketamine without the dangerous and addictive side effects the ketamine carries. This research is preliminary and will need to be replicated in order to confirm the study's findings. Further studies will need to be done to see if the antidepressant effects of the metabolite found in animal models will be reproduced in human studies. Finally, studies will need to be done to determine the long-term effects of such treatment in humans. If the results of these future studies turns out positive, this could be the beginning of a third generation of antidepressants that are both powerful and rapid-acting. And that's all, folks.